So I am here, I work at UCSF, and I am the manager of data and technology for Hilary Seligman's research team and also for the produce prescription program Vouchers for Veggies, known as Eat SF, locally in San Francisco. The first thing I want to do is to give a big thank you, they're not here, to Katie Ettman from Fulwell and Ron Lee Levi from my team. They were both very helpful in putting this presentation together, so a lot of you know them from this beautiful world. So in the interest of time, I actually all of my font got changed, okay. I'm not going to spend time on the Medicaid policy landscape, and I'm not gonna spend a ton of time on California's in lieu of service 1115 waiver program. It's known as CalAIM. The thing that's important to note is that it is very large. It is a Frankenstein waiver of both in lieu of service and 1115. It's very complicated. My program sits in this medically tailored meals, medically supportive food space. These are the other community supports that are offered through CalAIM. And then within the food is medicine pyramid, obviously there are a lot of interventions captured here, and today we are going to be talking about, I want to spend the bulk of the time talking about what Vouchers for Veggies is, and our experience trying to get a contract with a managed care plan and everything that we've done kind of leading up to this point, and all of the different barriers and how some of you in the room can maybe help facilitate those. So, like I mentioned, ooh, man, the font is killer here today. So V for V is a produce prescription program, and now I'm going to talk more in depth about what it exactly is. So I'm really excited to be able to represent Vouchers for Veggies today because we're both a relatively young CBO. It's our 10-year anniversary this April. April Fools was our first voucher spend. And we are also, with a relatively small staff, we're a team of about a dozen folks who work across both V for V and the Seligman research team. But we also are embedded inside of UCSF, and that means that we have access to all of the resources that UCSF's academic medical institution provides. So it's really interesting to be able to speak with that perspective. So like I said, V for V was founded in 2015. Since then we've served over 25,000 households. Super proud of that, through a network of over 150 community-based organizations and clinics with a robust local vendor network. So it was founded by Dr. Seligman, one of my personal heroes, and I also get to work on her team now, which is so incredible. Do meet your heroes sometimes, everyone. So the way that V for V works is it's a produce prescription in the sense that folks get either a paper voucher or a restricted spend card to purchase fruits and vegetables, which is a little bit different from some of the other folks I know. I have a colleague here who also does PPR, produce prescription, otherwise known as PPR, and some produce prescriptions are operated through a box model. V for V operates through this, through connecting clients to retailers, giving them purchasing power. And participants are enrolled through either a CBO or a clinic provider, and our doses right now range from $40 to $110, and the time period range is 6 to 12 months. We've had really, really positive results so far, including my personal kind of favorite one to bring out is that the behavior change associated with produce prescriptions, so the increased consumption of fruits and vegetables, which I don't think I need to convince you all has a positive impact on health outcomes and patient health, that behavior lasts after the program ends when we look at a 6-month duration. So what work have we done with healthcare already? So we started really deeply in the community, and now for a number of years, we've been building on that success and working with healthcare partners. So I wanted to highlight pilot programs that we have in Los Angeles through the LADPH through a Gus Schumacher Nutrition Incentive Program grant of theirs. I'm getting all my acronyms today. And then in San Francisco, we work through a Hellman Foundation sponsored collaborative called the Food for Health Collective. So we have partnerships with clinics and with other food providers in San Francisco. One other thing that we've done to prepare to scale for healthcare is we've onboarded a new fintech solution. We use Incom, the OTC network, to provide our patients, our clients, with restricted spend cards. And then we have been creating and iterating on healthcare referral pathways, customer service workflows, and collateral that can look really different than the work that we do with our more traditional kind of CBO partners. And then I'm sorry that this text is overlapping, but that says they're fortifying tech infrastructure to prepare for referrals and billing through healthcare. Easier said than done. So I'll start with our successes, and then we'll move on to the many challenges. So CBOs, I don't need to convince this room that CBO healthcare partnership is vital for a number of reasons. And the CBO healthcare partnership is really vital for the success of a program like CalAIM to provide all of these different community supports to this Medicaid eligible population. There's a lot of unique advantages, and at least for me, from V4V, I think the most important one is that there's just such a deep understanding of the local landscape, including the eligible participants, the clinic staff, the different players kind of at the different clinics, and also our vendor network. That's been really key. We've helped onboard vendors to the OTC network. That's a big national network. We've onboarded local BIPOC vendors in San Francisco to that network to be able to receive that benefit. And that's through relationship building that's been going on for the last 10 years. Our ability to adapt, we're more agile than some larger organizations. So we're able to adapt to the needs of individual health plans or clinic partners. And then also for V4V, our position within UCSF really uniquely positioned us to be able to do a lot of work with healthcare because we have access to enterprise tools and HIPAA-compliant data environments. That is not a luxury that a lot of CBOs have. All right, here are some of the challenges. I don't think I have time to go through every single thing here, but happy to take questions on it and connect about it later. But I would say the alignment on program model priorities and goals. The way that CBOs traditionally define success and the way that health plans define success can be really divergent. There's differing missions and priorities. Also, there's misalignment currently between the plan and clinic level regulations and the research program model. So I'll use California as an example. The guidelines that came down from our Department of Healthcare Services give a 3-month authorization period for food supports. All of our research says that 6 months is the minimum time period that a produce prescription should be administered in order to have positive health outcomes, and that is backed by multiple meta-analyses and other study aggregators, gray literature, et cetera. And then there's also a divide between the way that programs are implemented and the wants and needs of payers, but because payers have money, it's like you kind of have to acquiesce. I already touched on this a little bit, but obviously working in healthcare, there's strict HIPAA data security requirements. This is a really Herculean lift for especially smaller CBOs or CBOs that aren't used to working as covered entities with protected health information. Also, ensuring data privacy, obviously very, very important, but it requires significant technical and administrative lift, and some CBOs either aren't willing or aren't able to invest those resources. I'm gonna keep talking about data because that's in my job title and it's my area of expertise. But data sharing, we know this, often collected in silos, and it makes data sharing really difficult. Even with our most technologically enabled partners, we have a lot of trouble with bidirectional communication. We're not always signing a BAA, a business associates agreement, acting as a covered entity on behalf of some of our pilot sites, and so therefore we can't even see their patient information. We can't provide customer service to their patients. We're really siloed. Again, lack of a closed loop and bidirectional communication system. I just mentioned it makes it really difficult to coordinate. And I was just sharing with one of my colleagues that I was on my computer in a prior session because our SFTP went down. And we again are really well resourced. That is not something that most CBOs are willing or able to do, and that's a really standard process for how we exchange health information or financial information. And meeting security requirements takes significant resources, and that is, again, coming from somebody who has all of the resources behind me of UCSF. And then I also wanted to talk a little bit about billing and encounters, partially because I have Sarah here, and we did so much great work in our Coding for Food work group on developing new HCPCS codes. So one thing that we've run into through billing and encounters is around just configuration challenges, around getting even set up with health plans, getting configured to bill for those services. There's really one HCPCS code that we can bill under. It doesn't meet our needs. Hopefully there will be a new one soon. I know Sarah's already submitted to CMS to get a HCPCS code specific for produce prescription programs, but in the meantime, it's really difficult for us to actually bill. And each health plan has different requirement, even though these mechanisms are really standardized. Each health plan has slightly different requirements. They use a different platform. They want their data exchanged in a different way. So for us pursuing multiple contracts around multiple managed care plans, we're having to create completely different data and billing infrastructure for each contract that we get, and we don't know what the scale is going to be. So we're making an investment with an uncertain return. And also, we are not, this goes back to kind of the alignment on priorities, models, and goals. We are not set up as a CBO to create encounter data. That's not how we set up our data collection, and we're being asked to do that for a very good reason. But again, it takes a significant investment to ready ourselves. All right, so opportunities and strategies to support success. So again, I do not need to convince you all that CBOs are a vital part of the Medicaid landscape. And so some successes, or some, I guess, words of wisdom kind of standing a little while into it. I think my number one piece of advice is to start early. If you are a CBO that is looking to contract with healthcare, we started getting ready for this process before we had a contract, before we were really having serious conversations with our local health plans, because it takes a really long time to create all of that data infrastructure, onboard vendors, validate tools, and train staff. And this is especially tricky in the current landscape where a lot of these waiver programs are time limited. So I know we were like, oh, we're 4 out of 5 years into CalAIM, and most of us don't even have contracts. So the other things that I would say is understanding the healthcare priorities and reporting needs that could affect program implementation. So for example, if now you know healthcare plans really want encounter data, set yourselves up for success and figure out how to capture that. There's a lot of great resources out there to give you kind of a primer on healthcare billing. And then I have a whole bullet point cut off here. So collaborating with other organizations doing similar work. So we are, like I said, we're part of a Hellman-funded collaborative of multiple different organizations. I know that there's some folks here from network lead entities. I think that is a great tool for smaller CBOs who are really wanting to contract with healthcare but might not either want to or are able to make the investment to have those contracts on their own. And then I actually can't even see it on my screen, but I did have a bullet in there just talking about, I sit kind of at the intersection of a program and a research team, and one thing that we are thinking about from the research side, and I know I'm talking to a lot of folks who do research here, is actually looking at more investment in researching things that are priorities for health payers, which is really quite different from what might be a priority for social science researchers. I'd like those things to marry more closely, but the reality is that we're constantly talking about ROI, how to minimize medical loss ratio, things like that. So I would say that is my call to action for the folks in the room, is to look for CBOs to partner with if you are especially in the health economy, health economics research sphere. All right, I think I did it. I think I buzzed through this with enough time. Thank you guys so much.